throughout my first 30 cases, there was a learning curve, but I've learned little surgical tidbits or tips that have really made it easier for me, and I want to share with you some of these tips. If you've already used the DMEK tissue from the preloaded cannulas, this is a nice kind of adjunct to that with the DSAEK tissue, because it uses a very similar technique with just some modifications that you have to think about. So I'm excited to share this information with you. You should consider incision size as an important factor. You want the incision, I think, slightly larger than the minimum 3.2, closer to 3.5, because that allows the anterior chamber to inflate when you're injecting the graft and allows it to, you're going to keep the injector in there to keep inflating the AC, because that is your AC maintainer, and you're going to let the graft unfold. But you're also not making the incision too tight, so there can be some fluid egress out of the eye so that the pressure doesn't build up too much. And that will allow it so when you pull out the injector that there's not a high pressure system that's everything's rushing out of the eye.
30 minutes.
Perfect. All right. Just please gently pour that here in my hand. We have BSS underneath in a basin, which provides a nice safety net. Next, I have a 5 cc syringe filled with BSS, no bubbles. I take the transplant-ready LEITR tissue and I connect it and gently turn. At this point, I'm almost done. I don't do anything in addition. I leave the Optisol in there because later when I inject it into the eye, I will flush the Optisol out of the eye. So right now the connections are tight. Everything looks good. There are no bubbles. So the final step before I bring the transplant tissue over to the patient is I remove the cotton at the tip of the glass cannula. Now I do this submerged in BSS. This ensures that no bubbles enter sort of the end of the cannula. And if there were some bubbles or if there's air at the end, what you'd want to do is I put my finger on the top of the glass cannula here and I gently bring some BSS forward with the whole cannula and the whole device facing upwards. And I do it not by pressing on the plunger because that's too rough and it's too abrupt. I do it by gently moving this up here. There we go. So this tissue is a lot more forgiving for that than the DMEK tissue. You don't have to worry about the graft expelling out unless you use a lot of force. So we're ready to use this tissue now. So this would be under the microscope, which would make this a lot easier. But I would basically go in with the graft with bevel up, because I know when I'm bevel up, I know that the folds are below, and I know that we have the tissue up here where I can grab onto. So I go up here and I gently grab the edge and I just pull it about 1 millimeter, and that kind of breaks any sort of suction that could be present. I'm now using a 3.2 millimeter blade to open up the old cataract incision and slightly enlarge it to about 3.5 to 3.6 millimeters. We have BSS underneath in a basin, which provides a nice safety net. I take the transplant-ready LEITR tissue and I connect it. And this ensures that no bubbles enter sort of the end of the cannula. The next step is I will take a Reverse Sinskey to gently just nudge the tissue a little bit towards the bevel just to loosen up any sort of adhesions that could be between the stroma and the vice cannula. Because the incision is 3.5, I can very easily go in, bevel down, and then twist once I'm past the pupil to make the cannula bevel up. This is the same way that I do DMEKs as well. Once I'm in there, I start injecting in pulses, quick little pulses, and eventually the graft should come out nicely. Now the most important part here is do not come out of the eye too quickly. Stay in the eye. You saw I went almost back in, further into the eye. Keep injecting in pulses to unfold that graft and twist the cannula as needed. Next, I put a suture through the main incision, just a 10-0 nylon. I do a slip knot. I don't tighten it all the way just yet. just to keep that sealed so when I put the air in subsequent steps, it will not leak out of this incision.